Welcome to Grand Rounds at the UCSF Osher Center for Integrative Health. My name is Shelley Adler, and I'm the director of the Osher Center. Today, it is my truly great pleasure to introduce Dr. Zindel Segal. Dr. Segal is a distinguished professor of psychology and mood disorders at the University of Toronto Scarborough. He's a truly renowned clinical psychologist whose research examines the use of mindfulness meditation in promoting affect regulation skills in people with depressive and anxiety-based disorders. He's particularly well known as being one of the co-developers of mindfulness-based cognitive therapy, MBCT, which was originally developed to help prevent relapse of depression. I actually have the honor of collaborating with Dr. Segal on a project that our very own Dr. Rick Hecht is leading on maintenance strategies for MBCT. Dr. Segal's research program uses brain imaging to identify neural markers of depressive relapse or resilience associated with long-term practice of mindfulness meditation, also evaluating the efficacy of digital mindfulness interventions in increasing access to care. His work has provided empirical rationale for offering training in mindfulness meditation to people with recurrent depression with truly remarkable results. Dr. Segal has authored over 200 scientific publications and 10 books, including The Mindful Way Through Depression, which is a patient guide for achieving mood balance in everyday life. After Dr. Segal's presentation, we'll have about 15 minutes for discussion. So I want to encourage you to send questions to me through the chat feature and do that anytime through the presentation. And then after the presentation in the Q&A section, you're also more than welcome to pose questions directly and just turn on your video to indicate that. Lastly, I would like to thank our Grand Rounds Planning Committee, which consists of Dr. Selena Chan, Anna Druva, and Patty Moran, as well as Jen Shea, Yvette Coulter, and Julia Burns. So now please join me in welcoming Dr. Segal.
Thank you, Shelley. I have to say that I've had a long-standing relationship with collaborators at UCSF, and I've thoroughly enjoyed the opportunity to meet with great minds in San Francisco, starting with Marty Horowitz, who organized
Yes.
psychotherapy, depression, a node of the MacArthur Network, and that whole group, and then Stu Eisendrath and his whole group, and now Rick Hecht, Shelley, and Jen, and just, it's been wonderful. So I'm really happy to continue a longstanding collaboration.
Thank you.
I'd like to get started with my talk because there's a lot of things to get through. Let me just share my screen. Shelley, is this coming through okay?
Yes, it is.
Great. Okay. So as Shelley mentioned, I'm going to be focusing on mindfulness meditation and its role in relapse prophylaxis and mood disorders. Here are my disclosures for the audience to look at. And let me go back to the past in order to situate ourselves in the future. A lot of this work came from an initial large-scale randomized control trial funded by the NIMH, whose findings actually made the headline front story of the New York Times in 1986. And in those days, there was an animosity. It might have been a collegial animosity, but there was certainly a kind of academic animosity in discussing the best treatment options for people with depression. And there was a sense within the biological psychiatry community that depression was a biological disorder and that it required biological pharmacological treatment, and the psychotherapy community argued otherwise. NIMH funded what at that time was the largest psychotherapy outcome study comparing imipramine, interpersonal psychotherapy, and cognitive therapy and placebo for the treatment of depression. And the findings were that psychotherapy conditions were as effective as the pharmacotherapy conditions in treating depression. And this was a very large story, and it also allowed psychotherapy to begin to be taken seriously in the context of treating depression. Um, and it started a good deal of interest in what types of therapies can be most efficiently provided for people with depression. And as the picture of what depression was became increasingly more fleshed out, the different types of therapies that were sequenced to the different phases of the disorder. And in the cognitive therapy world, um, the question of treating depression was added to the question of how people who have been treated continue to stay well. And so the recognition that there was the need for not just treatment of the acute episode of depression, but the possibility that what people learn in therapy could be used to allow them to become their own therapists once therapy is over. Pharmacologically, people are able to stay well because they continue to take their antidepressants over longer periods of time, continuing even into remission and into recovery. But this was an early study by Steve Holland and Mark Evans et al., who found that the effects of cognitive therapy in people who had recovered from depression could provide similar benefits to people who continued to uh, take their antidepressant medication over a 2-year follow-up. So what we see here is everyone entering this follow-up study essentially in remission. And the people who fare the worst are those who come off their medication and receive a placebo, or actually no continuation. So they're just taken off their antidepressant. People who continue on their antidepressant do very, very well. And people who receive cognitive therapy to achieve remission and continue to practice those skills, but do not continue with cognitive therapy, in a sense, having internalized some of these skills to prevent relapse, do equally well. And so these data supported the findings of the larger NIMH Treatment of Depression Collaborative Research Study and suggested that psychotherapies could have in them embedded elements that people could use once they were no longer seeing their therapist to stay well. And this is actually very important because the epidemiological data on depression, which were collected, I would say, in the late 70s, early 80s, suggested that depression has a specific course and is no longer seen exclusively as a single episode remitting disorder. Instead, we see that there is a natural progression of symptoms, which, if the person is provided with acute treatment, can lead to remission and eventually recovery if remission is sustained. But the follow-up data suggests too that while people are in remission, the risk of relapse continues to remain high. While people are in recovery, the risk of recurrence continues to stay high. And that depression actually, for many people, not for everyone, but for many people, can be a recurrent and chronic debilitating disorder. And so there was tremendous interest in understanding what kinds of treatments could be provided to people while they were in recovery or in remission, when their symptom burden was fairly low, to allow them to protect against the onset of new episodes. And the important public health impact here is that new episodes were estimated to carry about a 16% risk for future episodes. So people with 5 past episodes had about an 80% chance of having a 6th episode, for example. But if one could prevent new episodes, then one could beat back, if you will, the odds for the condition becoming chronic. And this is really the domain in which MBCT, maintenance psychotherapy, maintenance pharmacotherapy is operating. And I would add, it's often a tough sell, because this is when people are being offered treatment while they are ostensibly feeling not a very large symptom burden. And so one of the studies that suggested the possibility of maintenance formats for psychotherapy was conducted by Ellen Frank at Western Psychiatric Institute and Clinic, published in 1990. And what they found was patients who entered a 3-year follow-up study, who were all in remission, um, were either continued on the drug that brought them to remission, and they had fairly low rates of relapse. So these are people here continuing on imipramine. And then there were people who received interpersonal psychotherapy once a month, developed to function as a maintenance form of psychotherapy. So once a month for 3 years. They didn't do as well as the folks who continued on their antidepressant medication for 3 years. But they did significantly better than people who were taken off their antidepressant and provided a placebo. And so the idea here is that for many people who are not willing to continue for 3 years on a course of an antidepressant, who have side effects that mitigate their continuation or for other reasons, in other words, they discontinue their treatment, here is another treatment option that will provide a superior degree of protection for them compared to receiving nothing or discontinuing their medication. And at the same time, David Kupfer and the node that he was running in the MacArthur Foundation was interested in developing a cognitive therapy version of maintenance for treatment of depression. And I received some seed funding from that node to develop a maintenance version of cognitive therapy. And what I did was use the money really to have a series of developmental meetings with John Teasdale and Mark Williams, 2 colleagues of mine, to really ask the question, what would this look like? And I think we could easily have come up with a version of cognitive therapy that was scaled back and provided once a month, in a sense, very much what Ellen Frank had done in creating maintenance IPT. But instead, we took an approach that was informed by sort of experimental psychopathology and asked ourselves the question, what is the best evidence for a treatment target that is associated with a high risk of relapse? Are there any processes psychologically that people engage in that increase their risk for relapse? Could we teach people skills for disengaging these processes and see if that has an effect on reducing the risk for relapse? And at the time, a lot of research that John and Mark were doing in the area of mood-dependent changes in cognitive processing suggested a link to rumination and a link to relapse. And some of the data comes from studies, a study that I conducted where we brought people who had recovered from depression in for a mood induction. We played music that was, I would say sad and a little bit boring to listen to, and asked them to also recall a time in their lives when they felt sad. And this induced some mild sadness that lasted about 5 or 10 minutes. But we used that as a window into evaluating certain thinking styles that were associated with depression, had them rate their thinking before they listened to the music, had them rate their thinking after they listened to the music. And what we found was that there were people who really didn't change their endorsement of these negative thinking styles. This is the dysfunctional attitude scale. Didn't change their endorsement of these negative thinking styles at all. And that's the flat line. Here, minimal change. There were people who showed somewhat of an increase in their thinking styles to become more positive. And then there are some people who, even over the course of a 5 or 10 minute sad mood, really changed their thinking to endorse far more negative thinking styles as a result of experiencing sadness. And so when we followed all of the people in our study over 18 months to see who relapsed, we found that the people who were perturbed enough by the sad, brief mood they experienced to endorse increased number of negative thinking styles had significantly higher rates of relapse over 18 months than people who were able to tolerate the sad mood without flipping into a greater endorsement of depressive thinking styles. And we felt like this was the kind of encapsulation, if you will, of one of the challenges that people who are in recovery from depression face. Can't avoid feeling sad. No one can. And how they regulate that sadness as it shows up in their lives, even after they've recovered from depression, can be a tipping point that may determine whether the sadness remains brief and innocuous, as opposed to something which starts to become a cascade of negative thinking, judgments, binary views of the world, and then maybe recruits further negative affect and becomes more clinically concerning. This was our target. This was what we thought we would try to find a way of helping people work with. And so we went back to the cognitive therapy world and looked at, how does cognitive therapy help people reduce relapse? Remember, the Evans study had a lot of evidence that cognitive therapy has skills embedded inside it that can help prevent relapse. And we looked at the thought record, which is very much pervasive in cognitive therapy, clinical care. It's used to help people recognize automatic thinking and describe negative affective situations. And when we looked at this thought record, instead of focusing on the content of what it asks people to do, we saw it as training certain skills, skills in distress tolerance. So, for example, a patient comes to a therapist and is asked to be very declarative about situations in which they've experienced negative affect, the problem that occurred, unresolved situation that is still bothersome, and also to look into that situation and the description of that narrative for emotions and to rate the intensity of the emotions. And even further into that situation to talk about any thoughts they may have had, especially initial thoughts, fleeting thoughts, automatic thoughts, things that just came into one's mind that seem to have a high degree of credibility. And so there's also training in recognizing automaticity. And then this idea that the thoughts that we have are concepts, hypotheses, interpretations that can be evaluated, for evidence that support that outlook or evidence that work against that outlook being valid. And so there is this idea that thoughts that we have are mental events rather than facts or absolute realities. And that's one of the things that the thought record trains. And then also the balanced viewpoint, putting all of this information together to come up with an alternative view or another type of thought or perspective requires curiosity and willingness to investigate and explore rather than a judgment. And all of these skills in cognitive therapy, we felt had the advantage of allowing people to work with their thoughts in a way that provides them with some psychological distance, to take a step back from thoughts when they appear. And this is something which, we didn't discover. It had been written about, continues to be written about in psychotherapy through many different guises, and it appears in different language systems, different terminology, some of the same terms for what we were talking about. Things like self-distancing, decentering, observing ego, diffusion, metacognitive awareness, disidentification with mental contents. That's what we saw cognitive therapy being able to train. That's what we felt people who were trying to prevent depression and stay well needed to learn. And we knew that cognitive therapy developed and could deliver that through thought records, but we also thought that it was I guess the best way to say it, it was hit or miss, depending on your therapist, depending on how they taught the thought record, depending on whether that was taught in a way that emphasized decentering or whether it was taught in a way that emphasized content. You could or couldn't have that experience as a result of receiving cognitive therapy. And so we wanted to know if there was a way of training decentering, of training that metacognitive capacity more directly. And part of the story of MBCT was that at the time that we were having our conversations, there were other people who were helping us and providing us with valuable perspectives on how that type of more direct training could be achieved. Um, One of those was Marshall Linehan, who was doing a sabbatical in Cambridge at the time, which is where Mark and John were, and was curious about their trips to Toronto and what we were talking about. And she told us about John Kabat-Zinn, whose work in using mindfulness in the treatment of chronic pain very much had a focus on featuring mindfulness meditation as a way of developing the capacity for decentering, for watching thoughts come and go, for watching thoughts move through the mind, rather than getting identified fully with their content, watching their movement. And that this required people practicing mindfulness meditation. And through these types of encounters, we went to UMass Medical Center, sat in on some of John's classes, and felt that there was some overlap between what the capacity of mindfulness meditation was to train people in these skills and the possibility that this would be helpful in preventing relapse and depression. And for MBCT, we had three main hypotheses. One of the things I would ask you to pay attention to is that for us, mindfulness meditation was driving our efforts to address the therapeutic targets that we thought were associated with risk for relapse. We didn't come into this as dyed-in-the-wool meditators who wanted to find a way of teaching more people in the world how to meditate. But the rationale, when we understood mindfulness, and I would say once we started to practice it ourselves, which is really key, made increasing sense. And so there were three main hypotheses that we had. The first was that mindfulness meditation offered direct training in decentering, more direct than, say, what you could get from working with a CBT therapist. And to be fair to CBT therapists, there's a lot more that they have to do if they're treating someone in an acute episode of depression than only training decentering. Decentering is anti-ruminative, and lower levels of rumination would be associated with greater depression prophylaxis. We incorporated inside our MBCT framework a kind of gradient of awareness practices that allowed people to start at a very approachable, tangible place in order to build the same awareness skills that they would want to then apply to the regulation of negative affect. So, as is the case in MBCT, as is the case in MBSR, the first objects of attention are essentially objects that can be apprehended very easily. They give out a strong signal. If you're holding a raisin, if you're eating, if you're taking a shower, if you're chewing, there are activities that you can bring your attention to that are easily locatable in space and time. And then as the gradient becomes a little bit more subtle, we move to looking for attending to investigating sensations in the body, sensations produced by activities that are usually automatic, like walking, stretching, and then moving to somewhat more subtle objects of attention, like the breath, sounds, working with thoughts, which eventually you can't really hold in your hand or locate in a physical location, but you can still have the experience of watching them come and go, having them, not having them, mindful, mind empty. And finally, to introduce an emotional difficulty into the space created when the mind is settled in meditation, to examine how it shows up in the body and in thoughts and in emotions, and seeing that as something that can be held and observed, once again, from this decentered perspective, which paradoxically actually provides more of an opportunity for engagement. And we incorporated these concepts into the MBCT session content, which emphasizes, if you will, the first 4 sessions of the program being a way of training awareness and training attention. And let me just go back to this previous slide. When people start to sit with thoughts or sit with a difficulty, this doesn't happen until session 5 of MBCT. So they've had 4 sessions of beginning to develop the basic awareness and attentional skills to allow them to take on things that might be a little bit more overwhelming, a little bit more chaotic to try to understand and even observe. And then the second half of the MBCT program is really intended to help people put the fruits of awareness into action. There's a way in which we feel that awareness is an important sequence for people to be able to use in order to make choices about how to regulate their emotions or how to activate themselves or how to notice activities that are depleting their energy. But that awareness or attention or mindfulness itself isn't sufficient. The goal isn't to increase people's mindfulness on it for its own sake. It's to use mindfulness that may have been developed even germinally to help people make choices when sadness comes back into their lives, when there's been a setback, when there's been an argument, when there's been some type of disappointment. And this takes us back to that initial study of inducing a brief negative mood and noticing for some people that that recruits a large amount of negative thinking. And so here, as setback or disappointment shows up, to try to limit that type of recruitment, and mindfulness and the ability to watch and work with thoughts differently allows people to do that in a more concentrated way. And so we've written a book for therapists, a book for patients, a workbook for participants in the class to try to disseminate these very ideas. And there's also been a very positive and growing evidence base to support mindfulness-based cognitive therapy for just this very purpose. And I'll talk about 3 studies that I think are very impactful and speak to this point. This is a study from the Lancet where patients were treated to remission with an antidepressant. And then for 2 years, patients in the blue line here continued to take their antidepressant medication. And patients in the red line here received 8 sessions of mindfulness-based cognitive therapy with support to taper off their antidepressant. And about 70% in this group here tapered off their antidepressant medication, relying only on the protection they received from participating in an 8-week MBCT group for prevention of relapse. And what you see is essentially no difference between these 2 groups, suggesting that the amount of protection offered by MBCT is on par with what people would receive if they're continuing to take maintenance pharmacotherapy. And this is really important, not to make the argument that one is better than the other, but to make the argument that for people who can't tolerate, let's say, maintenance pharmacotherapy, which still remains the standard of care, there is an alternative that can provide a significant amount of protection. And I think that that's important for, say, women who are looking to become pregnant or who are pregnant and have concerns about using antidepressant medication. There are other ways of protecting themselves, staying well. This is a study that we conducted to provide more of a definitive test of the comparison between antidepressants and MBCT. So once again, everyone in this study came to our 18-month follow-up treated to remission with an antidepressant. One group continued their antidepressant, that's this dotted line. So for 18 months, they got well on an antidepressant, they stayed well on an antidepressant. This other group in the dark black line came off their antidepressant and received MBCT. You can see here, there's no difference in relapse. Sorry, no difference in survival between these 2 groups. So replicating the Lancet study. But this group here were treated to remission, and then as they entered the follow-up, their antidepressant medication was replaced by a placebo. And the placebo group had the lowest survival, significantly lower than folks who continued on their medication or had MBCT. In a sense, taking away whatever protection they had and providing placebo, not surprisingly, led to poorer outcomes. And this is a more definitive way of arguing that the pharmacotherapy in this study was adequate enough because you get the separation from placebo, and MBCT seems to be able to hold its own. And then the final study is a meta-analysis of about 1,090 patients from 9 clinical trials worldwide. And it basically shows an advantage of about 31% for patients who received MBCT to prevent relapse compared to people who didn't receive MBCT. And I think these 3 studies help to make the case that the efficacy question of how well does this treatment do in this specific context of prevention of relapse is very strong and very supported by good empirical outcomes. And it raises the question of, well, then how does MBCT actually achieve its effects? What are some of the mechanisms? And the mechanistic research, I think, is what I want to speak about next, with some interesting hypotheses, I think, for what's going on. In order to examine that, we conducted a study where we compared MBCT with cognitive therapy in people who had recovered from depression. And we followed people for about 2 years. And what we found was that both of these treatments had very low rates of relapse. They were both very effective, and there was no difference between them. So CBT presented as a wellness treatment, and MBCT, which is wellness oriented in the sense that we're not treating acute phase clinical disorder, both led to relapse rates of about, I think, 22%, compared to the expected relapse rate in this more recurrent population of around 50%. And because we're psychologists and we couldn't resist the urge to provide people in the study with multiple measures across this 2-year follow-up, we had a large number of self-report measures that we used a factor analysis to condense into 3 factors and to see how they changed over this 2-year follow-up. And these factors showed skills in a number of different areas. One of the factors was a factor associated with distress tolerance. And what you can see here is that distress tolerance skills continue. This is pre-treatment, this is post-treatment, the dotted line, and this is the 24-month follow-up. Distress tolerance skills grow during acute treatment. They continue to grow over the 2-year follow-up. Decentering skills grow during treatment, continue to grow over the follow-up. Residual symptoms essentially stay flat over the follow-up. So there's no additional gain either in worsening or decrease of residual symptoms over the 2-year period. But there are some people who show the capacity to improve their abilities at stepping back and watching their thinking or tolerating negative situations. When we enter these 3 different factors into a Cox regression to look at survival, we find that the residual symptoms do predict survival, but that decentering, the extent to which increased growth and decentering occurred for people, was protective over 2 years. So people who showed high growth over the follow-up, remember, they're no longer in treatment. They're not receiving any MBCT classes, but they're still practicing something that is helping to build their decentering skills, do consistently better than people who showed low growth or no growth in decentering. And when we talk about the relationship between frequency of practice or how well people were using these skills, we found that decentering made a huge difference in relapse, which is sort of what we saw here. But we didn't find a lot of evidence for the amount of either cognitive therapy or mindfulness meditation practice during the follow-up in terms of impacting relapse. We did find that if people practiced whatever, either meditation or cognitive therapy, during the course, they were more likely to practice during the follow-up. And practice during the follow-up was more likely to build decentering, which was negatively correlated with relapse. But practice during the follow-up itself, if it wasn't building up decentering, was not associated with a significant reduction in relapse. And so what it suggests is that mindfulness meditation offers direct training in decentering, and so does CBT if both of these are taught in that way. And that growth in decentering via mindfulness or CBT does provide greater depression prophylaxis. And when we talk about decentering, we usually have a very cognitive sort of mental frame on that. We talk about thoughts, we talk about stepping back and observing. But when we look at the neuroscience of what actually happens to people who have a history of depression and are exposed to sad moods, we get a bit of a different picture. So I'm just going to talk a little bit about some of these findings from recent neuroimaging studies because they are very important to the conclusions in terms of mechanisms. In 2010, we published a paper looking at essentially replicating this negative mood induction, the sad mood induction that we did, except we did it in an fMRI scanner. And we had people watch sad clips of movie films in which sad things are happening from the champ, terms of endearment, usually a parent dying or having an illness, versus neutral clips from home and gardening, crafts, television shows. And what we found was that the insula and somatosensory regions in the brain were deactivated when people felt sad, and that more frontal regions associated with executive network were activated when people felt sad. So people were, in a sense, engaging in a relationship to this sadness by trying to figure out, what do I do about this? Is this a problem? What does it say about me? And having less of a sensory or interoceptive experience of the sadness. And when we took a look at the relationship between the degree to which the insula was reduced in activation, we found that there was a negative correlation between depression scores and insula activity during sadness. So while people were feeling sad, if they deactivated the insula, they were more likely to have a higher depression score. So there's something about the loss of sensation, the loss of sensory processing during an emotion, and a over processing, if you will, in terms of cognitive and control strategies that seem to be associated with increased depression scores. And then we replicated this study. So we used the same images, the same task in the fMRI, and we compared people who had had cognitive therapy or mindfulness-based cognitive therapy, basically the same people that we studied in the 2018 paper. And once again, what you find is, if you look here, the yellow regions are the frontal executive control network regions, very active. The blue regions are the parts of the brain that get deactivated. These are some of the sensory regions that are getting deactivated. So if you look at people who just generally experience sadness, these are the patterns. And if we take a look at the effects of relapse, what we find is that people who relapsed showed a significantly higher degree of deactivation or inhibition of sensory regions. if you plug the degree of inhibition in sensory regions into a survival analysis, you see that the somatosensory reactivity to sadness. So when people feel sad, they turn down sensory regions, they turn up cognitive control regions. Significant difference in survival with people who lose sensation have a much lower probability of survival. In other words, a much lower probability of relapse, a much higher probability of relapse than people who are able to keep sensation alive in the face of sadness. And there is also a way in which the effects of treatment, these are very suggestive data. The effects of treatment are to help to dampen some of the frontal control regions in having an effect of inhibiting sensory regions. So to the extent that the lateral prefrontal cortex following treatment was reduced in its activation, there was the potential to recover more sensory information. And in survival analysis here, the change of lateral prefrontal cortex reactivity, in other words, the quieting of the lateral prefrontal cortex and allowing more of the sensory signal to come through, was associated with higher probability of survival than people who weren't able to learn how to deactivate or inhibit the lateral prefrontal cortex. Now, I know this is a lot of information to digest. I just wanted to provide you with the idea that one of the ways in which people were able to prevent relapse through the skills of either of these wellness therapies was to recover and to stay with sensory experience during the experience of sadness. And so we're starting to pivot to the idea that somehow promoting sensory processing through sense foraging and other types of activities may be a very important mechanism above and beyond decentering, or that sense foraging or sensory processing may support or spur further decentering rather than working exclusively through a kind of cognitive or thought-based channel. And you can think of sense foraging as having a number of access points, or access to sensory experiences having a number of access points. Meditation definitely figures as one of the access points for sense foraging, but so does walking in nature, so does exercise, so does art, so does travel, so do psychedelics. And you can also think of a grid in which number of access points are things that people can do on their own, or people can do in supported contexts, and things that people can do on their own that have high access. For example, take a savoring walk in the park, or lower access, climb a mountain. High access autonomous, take a brisk walk in the park, or low access, go surfing. Supported exercise, a neighborhood running group, or low access, circuit training with a coach. Even meditation, high access, do it on your own, personal practice. Low access, go to a silent retreat. The point that I'm making is when we reconsider our hypotheses, it's important that we see the dysphoria, the sadness evoked deactivation contributing to the return of depressive episodes. Vulnerability may be mitigated by targeting prefrontal regions that are sensitive to clinical intervention, and that the newer iterations of MBCT or mindfulness in the context of depressive relapse prophylaxis may be enhanced by reducing prefrontal cognitive processes in favor of sensory representation and integration. And reducing prefrontal cognitive processes may require stepping out of cognitive modes in order to do that. And one of the ways of stepping out of a cognitive mode is to step into a sensory mode. So I'm going to leave it there. I know that I've covered a lot of material. I hope some of it is interesting and provocative enough to generate some questions and answers, and I'm looking forward to our discussion. Thank you.
Thank you so much. Yes, absolutely, on all fronts. Fascinating and obviously critically important work. I will begin with some of the questions I've received already and invite people to either continue to send questions to me or come on video to ask them of you directly. The first question has to do with individual versus group format. Is MBCT approached individually ever? And let me continue the question. And if not, what is the impact of group MBCT?
I mean, I think the reality is that many therapists provide therapy in a individual format. And so MBCT can be provided in an individual format. The Mindful Way workbook was written to support individual MBCT. And I think it's important for the therapist to recognize that there are gains and losses in that type of format. Your patient gets a lot more of you than they would get in a group format. They get access to you in a way that allows different times of not knowing or of understanding or confusion to be referenced directly by asking you questions, and they get you guiding them directly. What you do lose, though, is the capacity for learning in a group context that provides a demonstration that many people have the same mindsets and the same concerns and the same judgments that you have. And so watching other people go through those kinds of um, worries and limitations can sometimes be reassuring about some concerns that we have. So you do lose a little bit of that vicarious learning, but it can certainly be done in an individual context.
Thank you. I want to share, and as you mentioned before, the benefit of participating in different practices oneself
Mm-hmm.
before and while studying them. You know that both Rick Hecht and I have taken MBCT courses because of our study with you, and I was really struck personally by exactly what you're talking about, a kind of a normalization and a group alignment that seemed to be extremely beneficial for people. Another question is, has MBCT proven successful in different cultural contexts? Is there anything about the context as well as sort of international setting that you have noted?
You know, that's a great question. Proven successful. Like when I hear that, I'm thinking, has it been culturally adapted? Has it been, disseminated in ways that maybe change the framework? And I don't know exactly. I mean, I think from the beginning we were very explicit in telling people that there's a modular format to MBCT. So if you're wanting to modify it, say for treating eating disorders, you probably need to change the order of the sessions or the practices. You wouldn't want to start with a raisin exercise that might be activating, but you could still work on developing awareness through different things. I know that, for example, MBCT is very popular in China. Now, I don't know whether there has been a thinking through of the MBCT format as it is needed, or if it is needed to accommodate that population compared to its use in North America or in Europe. Um, and of course, the points of contact in Chinese culture with meditation, these are concepts that are not as foreign to them as they might be to us. Um, so I think we've given permission, but I'm not aware of a lot of cultural adaptations. I know there's some work in the Philippines with MBCT, um, and people do go back and forth in terms of wanting to stay close to the protocol versus changing it to meet the needs of the local community and make it more disseminable.
Yes, yes. Sounds like there's some work for future medical anthropologists there. Let me see. In your view, what are some of the most exciting new frontiers for prevention of depression relapse and or MBCT specifically?
Um, so for me, I mean, I think I'm going to go down the sensory processing, sense foraging path in the next little while. Because I find that what people need are access points. And access points are a way of them engaging and starting to become hooked into some form of practice. Now, when I was first starting out with MBCT, those access points were quite rigid and informed really by the precedent set by John Kabat-Zinn and the MBSR community, where, it's like, you're not sitting for 40 minutes, you're not practicing a lot, then there's a way in which you're missing out. And I think the follow-up data and many of the ways in which we've seen the evolution of MBCT and MBSR, it indicates to us that people do not do that. They just do not do that, much as our intentions and our wishes might be for them to do that. The rates of practice during the program and the fall off after the program, the rates of engagement, they're not what we hope, and yet people still benefit. And so that's why I think access points are very important. I think sensory access points teach some of the same things that we might be able to teach through meditation, given the ubiquity, the possibility for immersion, and the possibility for naturally inhibiting these frontal control networks to allow sensory processing networks in the brain to become more active and to open us up to different types of landscapes. I think the access point issue is really key. It's also very scalable. And so there may be some versions of MBCT that incorporate those as practices versus staying with the much more delimited long-term meditation practices. Now, you can't get rid of that, because it's one thing to have awareness, but it's another thing to actually have awareness of available to you during moments of difficulty. And I think that that does come from longer periods of practice. But maybe this is some way of enrolling more people in the possibility of seeing that value.
Yeah, very, very interesting. Thank you. I want to invite Carter Lebers to come and ask a question. I don't know if you can come on video, Carter, if you want to just do audio, but please.
Hi, can you hear me?
Yes.
Yep.
Okay, great. I'm sorry, I'm driving, so I can't go on video.
Perfect.
But Dr. Segal, thank you so much for an exceptional talk. That was just amazing, informative, and inspiring.
Thanks,
As is your work. Yeah, as is your work in general. I have two questions for you. One is, when you were doing your factor analysis, how were you measuring decentering? That's the first one.
Yeah. So the factor analysis basically allowed us to combine 5 different measures of decentering into a factor, and not just decentering, but other measures that loaded on this decentering factor. So we had, the experiences questionnaire, the FFMQ, the rumination scale. We had a whole bunch of different measures that looked at decentering. But instead of analyzing each of them, the factor analysis allowed us to collapse the common overlap in those, and we labeled this factor decentering. It looked like decentering. Maybe someone else looking at it from another lens would have named it something else, but it allowed us to collapse a lot of different measures that had multiple points of overlap into a single factor, and then see how it grew over the follow-up.
Okay, that's great. I was hoping you were going to say you've discovered or developed a fantastic measure, because I think measuring decentering is really tricky. But maybe in a different conversation, I could ask your thoughts on that. The other question I have for you is, I know that both Cresswell and Davidson have reported on increased resting state connectivity between the dorsolateral prefrontal cortex and the posterior cingulate / precuneus after training in codified meditation, and that this increased resting state connectivity in both of those studies was associated with decreases in physiologic and or behavioral markers like self-reported perceived stress. So I'm curious, I think your findings about the neuroimaging results is really fascinating. And I'm wondering, these were not clinically depressed populations. They weren't looking at sad emotions, but it seems that the same 2 areas are the main players in these what were randomized controlled trials. What do you make of that? What do you think?
So the first caveat is I'm not a neuroscientist, so I know certain things and there's a lot of stuff I don't know. Um, but I do think that you're getting at something really important, which is that there's a kind of seesaw relationship between frontal executive control networks and sensory regions of the brain. And the more that the frontal control networks call the shots, the less we hear from the sensory networks. Now, in our study, the sensory networks were activated because people were looking at sad films. Whereas I think in Richie and David's studies, they weren't really being primed in any way. They were just practicing meditation and they were looking at the capacity for these attentional circuits, like the precuneus cingulate cortex, to be attached to some of these, the dorsal frontal regions. Um, but I think that when you practice meditation, there's a lot of sensory processing that goes on. Just following sensations of the breath coming into and leaving the body involves a sort of sensory training. And much of the meditation instructions are invitations to let go of control activities like judging, evaluating, um, looking for gain. And so the more that we let go of those, the more we let go of the frontal parts, and the more we create room for the sensory lateral regions to speak to us.
Yeah. Wow. I have to say your proposition of this as one or the underlying mechanisms feels like I just took a psychedelic to an access point. It's really
Psychedelics
expanding.
are an
So
access
thank
point.
you.
Thanks,
So
Carmen. Nice
thank
to
you
hear
very
from you.
much.
Yeah, good to hear from you.
Let's see if we can get one other question in here. And let's see, some people with depression and anxiety seem to experience their symptoms very somatically through the experience of physical symptoms that suggest sensory hypersensitivity. This seems the opposite of some of the what you presented regarding reduced sensory processing in relapsing patients. Can you comment on this seeming contradiction?
Yeah, I think that that's something that we don't fully understand. I know that there's also concomitant inputs related to trauma, related to pain disorders. And so those are situations in which there's hyperactivation of sensory signals and maybe not enough activation of inhibitory control of frontal regions. Um, I don't know. I don't know. I mean, it would be a great conversation to have. Yeah, I just don't know enough.
And one very last question by someone who notes that the evidence seems so clear in terms of MBCT. With a question is with people who have newly started antidepressants, are there insurance payers that are coming around to understanding of this value?
You mean in terms of coverage of MBCT?
I assume yes.
I know a lot of people who have coverage for MBCT under group psychotherapy. Can I go back to that other question about the sensation?
Yes.
Yeah, so I did have a thought.
Oh, please.
It would be wrong for me to suggest that people need to like fall into an ocean of sensation and then everything will be okay. I think it's really more of this exercise in toggling between increased access to sensory signals and a little bit of a decrease of the control activities for some people, especially people who are ruminating and who are kind of stuck in their frontal lobes and all they try to do is think themselves out of situations. They never interact with sensory input. And then there's other people, I guess, on the other side of the spectrum, which is what this questioner might be asking about, who
Yes.
are stuck in the sensory mode and are not able to toggle back into prefrontal control regions. And I think they would need strategies to move in that direction. And so the toggling is really the thing that we would want to be able to train. And you do have that even in meditation practices where you might move from exploring a more focused, concentrated type of awareness into a more open awareness. But you could go back and forth between the open spaciousness and then maybe moving into a region of the body where you're investigating one particular thing. Anyways, that's just off the top of my head, something that I thought I'd add.
Yeah, well, thank you so much. That makes a lot of sense in terms of adaptability. Well, I'm afraid we're going to have to leave a lot of questions unanswered because there's so much interest in your work and a lot gotten out of your presentation. So I want to offer my gratitude and virtual applause and thanks. Really a pleasure having you chat with us, Zindel. Thank you so much.
This is great. Thank you for inviting me. I really appreciate it. Take care, everyone.
Our pleasure.
Be well. Bye-bye.
Thank you, everyone.